In the updated analysis of the Telepro 2 trial from ASCOGU 2025, interestingly, both the DNA damage repair pathway positive patients and negative patients seem to have benefited from addition of talazoparib to enzalutamide compared to placebo plus enzalutamide. There was more benefit seen in patients with positive BRCA1/2 and other DNA damage pathway repair alterations compared to the patients who did not harbor those mutations, but again, benefit was seen in both patient subgroups. Updated analysis of CheckMate 274 study presented at ASCO-GU 2025 further confirmed benefit of adjuvant Nivolumab in patients with high-risk muscle-invasive urothelial carcinoma who are at a higher risk of cancer recurrence post-definitive surgery. There was an overall survival benefit reported with adjuvant Nivolumab compared to observation. Also, there has been further confirmation of disease-free survival benefit reported in patients who received Nivolumab. So, in my opinion, it solidified the use of Nivolumab in this patient population. Additional analysis of the Niagara trial data in the perioperative MIBC space showed continued benefit with addition of Durvalumab to standard of care cisplatin-based chemotherapy in patients who are planned for radical cystectomy. Although the addition of Durvalumab to neoadjuvant cisplatin-based chemotherapy is not yet FDA approved, it appears that adding immunotherapy early in this patient population leads to increased various outcomes, including pathologic complete response. I think that if the drug can be accessed at this point, then using it seems to be appropriate based on the very positive results of the Niagara trial compared to neoadjuvant cisplatin gemcitabine alone. In terms of biomarkers, we don't routinely yet use biomarkers in the neoadjuvant space, but in urothelial carcinoma, there are some biomarkers that are associated with improved responses to immunotherapy. For example, high tumor mutational burden and positive PD-L1 status. So it could be argued that those might be helpful when selecting neoadjuvant therapy, although the Niagara trial population did not select adding Durvalumab based on presence or absence of these biomarkers. These were unselected patients. So adding immunotherapy earlier in a disease setting in the neoadjuvant space seems to have a correlation with multiple positive outcomes. The point of care in clinic, we do not yet have access to testing that can provide us with RNA data. So this may not yet be applicable to clinical scenarios. However, intuitively, it's a very interesting idea of personalizing care and intensification of therapy in certain patient subgroups that may need enhanced therapy for their metastatic RCC frontline.